Hello. Good morning to all of you. And we'll start the session and the first talk of the meeting. Limbal stem cell deficiency. This is a patient that 17-year-old female who presented to us in LVP when she was 10-year-old. So first she underwent a limbal allograft, cultivated limbal allograft in one eye, and it worked well for some time. After a few years, she could not afford immunosuppression, so therefore the graft failed. And then in the left eye, she underwent a COMET, cultivated limbal oral mucosal epithelial transplant, followed by PK, and that also went bad after after 6 months. And this she becomes like this in both eyes. So in 2009, we did a Boston Type 1 K-Pro, and with that she is able to see in the left eye 20/20 N6, and she continued to have a good vision for next several years that I was following her. So when we say about limbal stem cell deficiency, we need to understand that the ocular surface is a complex structure which is maintained by the preocular TF film with its components, surface epithelium and the ocular surface sensitivity. And the various parts of the ocular surface consist of the mucosal epithelium exposed to the environment. The elements of the stable preocular tail film are compositional factors, hydrodynamic factors, and both of them are important to maintain the surface. And this balance is coordinated by two reflex arc at the brainstem level. The limbal stem cell deficiency or the limbal stem cell, the location and all that is now not a question. There's a lot of basic science research which talks about it and well documented. This is the transition zone between the cornea and sclera where the palisades of Vogt housing the limbal stem cells, and there is a niche, or you can call the limbal stem cell houses or apartments, where these cells are maintained and they grow out from there. These are the basically etiology of acquired limbal stem cell deficiency, congenital, immunological. This is a study that we had done in LVP between 2005 and 2014, and this is the till date largest study of limbal stem cell deficiency etiology, where you could see in 1,300 patients with 1871 eyes, the 60% of them, or the majority of 66 means 70% of them are male, and mostly both eyes are equally affected, and unilateral versus bilateral is 60 to 40, unilateral being more. If you look at the median age, it affects young adults in their 20s and 30s. But at the same time, you look at less than 15, pediatric age is also a substantial number. The visual acuity, most of these patients had a very bad visual acuity of 2200 or less. The extent of limbal stem cell deficiency, there was a majority of these patients had total stem cell deficiency. If you put 7 to 11 clock hours and total, that becomes about 70–80% of these patients. And these are the distribution of each cause. Ocular surface burns is by far the commonest cause. Then comes the VKC and AKC. Mostly VKC, I would say. AKC is very less. SJS or 10, the aniridia, mucous membrane pemphigoid, and unknown causes. If you look at the unilateral causes, 85% of the patients are due to surface burns. And bilateral causes are very different. They are mostly immunological mediated diseases. Ocular surface burns are one-third is VKC, and about 20–25% is SJS and 10. Within the chemical burns, the identifiable causes are lime burn being the most common. So if you look at the limbal stem cell deficiency, leads to significant visual impairment. Majority of them are chemical burn, and most of them are due to alkali burn. Unilateral versus bilateral, that determines the prognosis. Therefore, the causes are very different. And this is another classification which is published, is the based on the clinical presentation. You have stage 1, stage 2, stage 3, depending on the central cornea 5 millimeter affected or not affected. So in summary of this section, these stem cell deficiency can be dysfunction or destruction, and that will determine the treatment. For diagnosis, essentially diagnosis of LSCD is clinical, and these are the clinical features. And more here you can see there is a conjunctival ingrowth onto the cornea, because the limbus, loss of limbus causes the loss of barrier function, and conjunctiva grows onto the cornea, and this epithelium is unstable, so it may break down, causing recurrent epithelial defect and redness. These are the patients with VKC, with stem cell deficiency. Investigations, again, mostly diagnosis we make by slit lamp biomicroscopy and with fluorescence staining. Impression cytology is very rarely used unless you are using, if you are doing a research. For example, fluorescence staining can tell you much more about the surface and its health, especially the epithelium. The AIOS2025 intersegment AIOS2025 can give you little better insight about the depth of pannus, areas of corneal thinning, perforation. In vivo confocal microscopy can give you little more details, especially the cellular structure and subcellular basal nerve plexus. Management, mild cases, generally if it is peripheral and focal, then generally you need only topical drops or maybe scleral lenses. Moderate cases may need AMT, or severe cases would need stem cell, some sort of stem cell transplant, especially maybe SLAT, and severe bilateral may need keratoprosthesis. So this is another algorithmic approach, which is again published in one of our papers. This is more dramatic presentation. For limbal stem cell surgery, the cornea should be wet. There should not be any anesthetic component, and it should not, for an autologous transplantation, wet eye is preferred. So in SJS and OCP, generally the outcome of these treatments are not very good. So definitive management of stem cell deficiency, stem cell transplantation, it could be in the form of direct conjunctival transplantation, limbal conjunctival transplantation, or a CLAT, cultivated limbal epithelial transplant, or simple limbal epithelial transplantation. For bilateral, there are a variety of options, and we will talk about it briefly towards the end. And this is the rationale of doing the transplantation, because the limbus is lost, so you replace the limbus either directly in direct limbal grafting, or a cultivated, or a SLAT. And this is how the surgery was started by Safer Singh and Kenneth Kenyon way back in 1988-89. Biopsies they started taking from the corneal side. If you see the technique we developed, we start the dissection from the scleral side or conjunctival side and come towards the limbus, because this gives you an advantage of plane of dissection. With this, you know exactly which plane you are in. If you start from the corneal side, you don't know what plane you are. And this is a technique that we developed in LVP long back of cultivating the stem cells, and we did a very large number of patients, more than 1,000 patients, and the largest study was reported from there. And this technique now is come to know as, or reported as, LVP technique of culturing the stem cells. And these are the papers published extensively in this area. And this was the largest study in IJO. Then we started realizing, the cultivation depends on the lab, the cost is much more, and the patient have to wait for 2 weeks. So this technique of doing simple limbal epithelial transplantation came into being in 2009-2010, and the first paper appeared in BJO 2012. And the technique, as its name signifies, is quite simple. I'll skip the surgical video and look at the outcomes. If you look at the outcomes, this is like within 6 weeks, before and after. This is 3 years. And this is more than 10-year follow-up of the same patient. And this is another patient with 12-year follow-up. And these are confocal microscopy before and after. These are subbasal nerve plexus. And there's a unique thing we observed when we are doing this slat. If you wait enough, the cornea continues to clear. And this is the case in this patient, that vision improved to 20/40 in 5 years' time. So we conclude that currently the slat is the best technique, whatever the way you evaluate, and you don't need a lab, and the cost is significantly down, and it's a basically democratization of the stem cell transplantation. For bilateral limbal stem cell deficiency, there are different options, like K-Pro is one of them, and this is done extensively starting in 2009. This is a brief video clip. I'll skip, and these are the post-op management. So we have, two type of Boston type 1 K-Pro from Boston, Oro K-Pro from Orolab, and Lucia, another version from Boston type 1. We have been doing this technique since 2009, both. So Oro K-Pro we have done 54, and at that time, and this paper is published in AJO. So we wanted to compare whether the outcomes of performance of Oro K-Pro, our indigenous Indian-made K-Pro versus Boston-made, are any different. And to our satisfaction, we found that both K-Pros performed very well in different situations, and there was no significant difference in adverse events or retention rates. Briefly about cultivated mucosal epithelial transplantation, COMET. We take the biopsy of the lip, grow it like limbus, and these are some of the patients. We did about 19 patients, and after that I had stopped doing these surgeries because I did not find any significant improvement in the vision. And so for me now, if you look at bilateral LSCD, primarily it is the Boston type 1 K-Pro or a LO slat. This is old data, therefore I am just sharing. And these are some of the LO-CLAT patients. This is their graft survival of 3 different techniques. This paper is published in Ocular Surface. When you look at the results of these eyes, bilateral eyes, there were conjunctival limbal allograft in 11 eyes, COMET 19 eyes, LO-CLAT 28 eyes, and K-Pro 31 eyes of 30 patients. The visual outcomes of LO-CLAT and CLAI are comparable, and the results of all 3 modalities are better than those of the COMET. Sight-threatening complications are significantly more likely with K-Pro because if the things go wrong, the deterioration can be very, very rapid. Therefore, you have to be very, very selective, very careful. This is an example of a patient in which we did first LO-CLAT, and then after 10 years, when her vision started deteriorating, that I did a K-Pro. So this can also be a good option in bilateral limbal stem cell deficiency, that you do not do both eyes at the same time. You keep one eye as a reserve, as a stepney, and operate maybe 10, 12, 15 years later when you need. That way you can improve the useful vision for longer number of years. So COMET visual results to me are not very satisfactory. K-Pro, good visual outcomes, and immediate outcome can be achieved. LO-CLAT or LO-SLAT, now I do exclusively LO-SLAT, and that are giving very good results. So in summary, for unilateral and bilateral limbal stem cell deficiency in wet eyes, SLAT is the best option. For bilateral, you'll need systemic immunomodulation. K-Pro and LO limbal transplantation is a good option for bilateral patients, especially chemical burns. For immediate visual recovery, I would consider doing a K-Pro in bilateral LSC, especially if some young patient or a pediatric age group, I may do a K-Pro first rather than doing a limbal allograft. In these patients, you need to be having a lot of patience and considerate for patients' perspective. And you should keep always long-term perspective in mind because these complications do develop, and you should be efficient in managing those complications. Thank you very much. All right, we can go to the next talk.
Thank you, sir. Hello. Hello. Yeah. Thank you, sir, for those great insights into limbal stem cell deficiency. We now move on to the next talk by Dr. Prashant Garg on bacterial keratitis. Meanwhile, we would also like to welcome Dr. Rashmi Deshmukh, our moderator for the session, to please join us on stage.
Good morning, everyone, and at times it is such a pleasure to speak in empty halls also. I think the corneal infections, we all know, are much more common in low and mid-income countries, and it is estimated that they occur much more often than in the Western world. And based on the published data from these countries, the corneal ulceration in developing world is identified as a silent epidemic, and there is also a proposal to recognize corneal ulcers as neglected tropical disease status. Corneal ulcers mostly start with very simple corneal abrasion, which is the most important predisposing factor in developing world, or following contact lens wear. But soon these simple abrasions translate into corneal infiltrate and ulceration. However, if they are treated appropriately and quickly, they lead to corneal scar but significant preservation of visual acuity. But if you do not treat appropriately, these can continue to progress, leading to corneal perforation or even the loss of eye. And therefore, timely institution of appropriate therapy is very crucial in the management of corneal ulcers. But is there a single bullet to kill all these different cases of corneal ulcer? The answer is obviously no, because corneal ulceration is caused by a variety of organisms which would require a specific therapy with antimicrobials directed against each of these. So the objective of my talk will be to discuss with you the epidemiology of corneal ulceration, particularly focused around India and low mid-income countries. I'll also touch upon the clinical workup of a case of microbial keratitis and how do we differentiate non-infectious from infectious ulceration, as well as constitute a differential diagnosis as to which organisms are causing infection. I'll touch upon how to perform a good microbiology workup and then how to initiate medical management in these cases. Now, one should remember very clearly that microbiology of corneal ulceration is not uniform. It varies from region to region. Even if you look at epidemiology of ulceration in northern India and compare it with the southern India, you will find there are subtle differences in the organisms and their relative importance in causing corneal infection. But by large, in our country, close to about 50 to 60% corneal ulcers are caused by bacteria. And equal or marginally less number of the cases are caused by fungi. Parasites account for only 2 to 3% of all cases of corneal ulcers. Among bacteria, the predominant organisms are gram-positive organisms, accounting for close to 65% of all bacterial isolates from corneal ulcer, and gram-negative organisms account for roughly about 25% of all cases. Among gram-positive organisms, again, Staphylococcus is the predominant organism. However, if you go further down south, and from the studies published from Madurai and Arvind Eye Care Group, the Streptococcus is the predominant gram-positive organism in their series. Pseudomonas, by and large, accounts for close to about 20% of all bacterial isolates uniformly in different parts of our country. We should also remember that nocardia, although is rarely reported from Western world, in our country accounts for close to about 3% of all the bacteria that are isolated from cases of corneal ulcers. The next question that we should address is, can we identify causative organism based on clinical examination? Let us take the example of this 20-year-old female who presented to us with the symptoms of pain, redness, watering of 2 days duration. She was a soft contact lens wearer and used to occasionally sleep with the contact lens on. The first question that will come to your mind will be, are we dealing with a case of non-infectious inflammatory pathology, which are very common with contact lens wear, or are we dealing with an infectious ulcer, particularly keeping the history in mind? So whenever you are dealing with a central lesion which is larger than 1 millimeter in size and is associated with epithelial defect, severe progressive pain, severe progressive necrosis, you must suspect etiology to be infectious rather than non-infectious. Whereas most of the sterile or inflammatory lesions associated with contact lenses are peripheral in location, less than 1 millimeter in size. Epithelial defect is either absent or mostly in the form of punctate erosions. They have mild non-progressive pain and mild non-progressive necrosis. So once we have established that we are dealing with a suspected infectious keratitis, the question will be, what is the causative microorganism for this patient? A detailed history and a good slit lamp examination, including determining the size of epithelial defect and infiltrate, nature of infiltrate, its depth, edges, and surrounding cornea, are very crucial in helping us at arriving at an etiological diagnosis. How do we achieve that? Typically, rapidly progressive disease with suppurative infiltrate are caused by bacteria. And among these, Staph aureus, Streptococcus pneumoniae, Pseudomonas, and Neisseria are the common organisms that cause a rapidly progressive ulcerative keratitis. If we look at the case that I showed with the history of 2 days duration, a predisposing factor as contact lens, most likely the pathology is caused by the microorganism or bacteria rather than fungi and parasite. The slowly progressive disease where the history is in weeks and months and the infiltrate is localized are typically caused by fungi and parasite. At times, some of the low virulent bacteria can also cause a slowly progressive disease. Among them are Staph epidermidis, Actinomycetal, and Moraxella. You then look for a specific clinical characteristic. A very well localized suppurative infiltrate with minimal surrounding infiltrate is usually a feature of gram-positive bacterial keratitis. On the other hand, a necrotic ulcerative keratitis with intense surrounding reaction is the characteristic of gram-negative bacilli infection. Nocardia produces pinhead-sized lesions arranged in a wreath pattern, and atypical mycobacteria is characterized by the waxing and waning course. You will see scarring at one edge and the ulcerative lesion at the other edge of the ulceration. Fungi typically are characterized by having a dry-looking cotton wool-like infiltrate, at times can have pigmented lesions, and Acanthamoeba is characterized by ring infiltrate as well as radial keratoneuritis. These are examples of fungal keratitis and how the clinical feature is helping you to differentiate these from bacterial keratitis, a slide on your right side. So the clinical pearl number 2 is that it is important that we realize that corneal ulcers are caused by different organisms, and it is important to differentiate between them. A systematic clinical examination will help us arrive at a differential diagnosis, and characteristic clinical signs can be useful in identifying etiological agent. Are these clinical examination always helpful in making a definitive diagnosis? Is a question that is still under exploration even today. And I'll give you some example. This patient presented to us with a dense central infiltrate with almost intact epithelium. And we thought that we are dealing with the HSV stromal keratitis and treated this patient with corticosteroid. There was marked reduction in the density of infiltrate and the cornea, and the only thing that we noticed is that there is a persistence of this chalky white lesion on the corneal surface. We did corneal scraping and found multiple acid-fast bacilli which grew on the chocolate agar as well. This is yet another example where again the clinical picture looked like HSV stromal keratitis. We treated with corticosteroid and acyclovir. While the density of infiltrate reduced, there was an epithelial defect which finally became ring-shaped infiltrate, at which the diagnosis was very obvious and the microbiology proved that there was an acanthamoeba. Very recently there has been a paper in AIOS which looked at clinical differentiation between bacterial and fungal keratitis based on clinical feature, and they found other than feathery high-fat edges, there were no distinguishing feature between bacterial and fungal keratitis. And that's why you will find there are many publications that have highlighted that microbiology workup is important in a definitive diagnosis of etiology of corneal ulcer. So the clinical Pearl 3 that I can give you is that keratitis is caused by different microorganisms, but they have overlapping clinical features, and therefore laboratory confirmation is important. So what is a typical protocol for microbiology workup? We need to do corneal scraping using 15-number surgical blade as shown in this video, and take the sample directly onto the smear or culture plates. So we inoculate culture plate directly on the clinic rather than sending the material in a transport medium. The advantage of this strategy is that through microscopic examination, you are visualizing organisms. There is a growth, then you can identify using variety of biochemical tests, and you can even get antibiotic susceptibility. However, you will require a very well-equipped laboratory, support from trained microbiologists, and there is then additional cost, and sensitivity and specificity of microscopy as well as culture are relatively low in otherwise also microbiology proven keratitis cases. You may also ask that I do not have a microbiology laboratory, how shall I proceed in the management of these cases? You can have a very simple setup with a light microscope, and you can use 10% potassium hydroxide to identify fungi, and therefore you will be able to treat cases as bacterial keratitis if there are no fungi or parasite. Trypan blue is another important dye that can help you delineate fungi from other filamentous structure. And we have already known that confocal microscopy, although a valuable tool in distinguishing acanthamoeba fungi from bacterial keratitis, is an expensive tool to have. So microbiology confirmation is crucial, but it involves additional facility, expertise, and cost. But simple tests like potassium hydroxide or trypan blue can be of great value. So how will you treat these cases? Should you treat empirically or based on microbiology tests? Empirical therapy is only restricted for small ulcers. Those are less than 2 millimeter in size, with no evidence of fungal or acanthamoeba keratitis. And we should use only antibiotic for empirical treatment and call all these patients for follow-up within 48 hours to 72 hours. All large ulcers should be treated based on microbiology workup at a center where there is enough expertise in the management of these cases. Treatment with acanthamoeba, anti-acanthamoeba and antifungal drugs should be given only when these organisms have been documented. The second aspect of the therapy is, should you use monotherapy with fluoroquinolones or a combination therapy with antibiotics effective against gram-positive and gram-negative organisms. You have variety of drugs that are effective against gram-positive, similarly those effective against gram-negative organisms. Fortified antibiotics are commercially not available. They have limited shelf life. There are issues with their pH and tonicity, and they can lead to toxicity. Fluoroquinolones, on the other hand, are commercially available. Shelf life is not an issue. They have safe pH and tonicity, and they are non-toxic. And therefore, fluoroquinolone monotherapy became very popular. But what we are observing is that many of these fluoroquinolones are becoming ineffective, particularly against gram-positive organisms, and therefore they are losing their value as an empirical treatment in the management of keratitis. How do you modify treatment based on the culture results? The modification is necessary only when the response to initial therapy is poor. If they are responding very well, regardless of culture and sensitivity, you can continue your treatment with the original therapy. You must assess the response only after 48 to 72 hours of initial therapy, and then you should correlate culture or microbiology with the clinical diagnosis. To conclude, the management of keratitis requires a systematic approach. Microbiology workup helps start appropriate therapy, and empirical therapy should be done with antibiotic and reserved only for non-severe cases. Thank you very much for your kind attention.
Thank you, sir. After covering everything the postgraduates and clinicians need to know about bacterial keratitis, we now move to an informative talk on fungal keratitis by Dr. Venkatesh Prajna.
So good morning. I'll be talking about the diagnosis and management of fungal keratitis. So I'll first talk about a little bit about the diagnostic part of fungal keratitis and then go to the management part. In the diagnosis, how do you actually diagnose fungal keratitis? You can do it by clinical findings, look at investigations which you can do in your clinic. Microbiological investigations, as Prashant mentioned, is very crucial, and also the newer version of AI, which is now going to be in this realm, which will be extremely useful in the future to come. So in the clinical findings, these are the typical features which are described in the textbooks. Out of all these things, the only thing which is very typical for fungal keratitis is the feathery edges. Even though the other parts you can diagnose in the early stage of corneal ulcers, but in established cases, by really good research studies, it has been shown that the only thing which has of very, very clinical significance is the presence of feathery edges, especially like this. When you have feathery edges like this, you're fairly, it's confirmatory for fungal keratitis. But you see this case, this is how patients usually present, very, very non-specific. And you can see it in the periphery here is something like a lesion, like a central lesion. But then the first thing is to identify it or delineate it using fluorescein staining. And especially when you use fluorescein staining, you start seeing this feathery edges, which was not clear before you use fluorescein staining. So our advice will be not to shy away from fluorescein staining, at least in the early part of your career. But the same fluorescein staining, if you put it in a cobalt blue filter, whatever you see now becomes much, much more clearer. the feathery edges, almost like a flower pot appearance. Like the flower pot, some sparks coming out of it. So this is very, very typical. And if you have not used this, this is how it would have looked like it, and it would have been very, very non-specific. So these are very small things which you have in your hand, which you should use, and you will get remarkable results. In the clinical investigations, the only problem with confocal is they have stopped production of confocal. There are only 60 confocals around in the world. And the only big problem for that is there's no big market for this, and so this may be history. But confocal microscopy is very useful for acanthamoeba keratitis and fungal keratitis. It cannot be used to identify bacterial keratitis because the size is very small. In confocal microscopy, initially there were studies which said that you can differentiate fusarium and aspergillus. But a study from our institution, we were very clear that the IVCM cannot be used, and the branching angles at 90 degree and 45 degree are also not very specific for fusarium and aspergillus. So that was the clinical investigation. How about the microbiological investigation, smear, culture, and recent advances? One of the things which you should really do is to take the specimen correctly. Unless you are going to take the specimen correctly, the microbiologist is not going to give you a correct answer. And in one advantage in fungal ulcer is you can take it like a plaque. And when you take it like a plaque, it serves two folds. One, it gives diagnostic material for the microbiologist. Second, it acts as a therapeutic debridement so that the drugs can actually reach the deeper parts of the cornea in a much, much more perfect fashion. So in the light microscopy, if you have samples only for one smear, then do gram stain. Because in gram stain, you can see fungus, you can see bacteria, you can see gram positive, gram negative bacteria, you can see acanthamoeba, you can see everything. So if you have sample only for one specimen, one test, do gram stain. Otherwise, a KOH is a simpler test for detecting fungus. Any clinician who with repeated examinations can develop these expertise. So all things which look like a filament in KOH is not fungus. As you can see in this, you can have fungus, which is much more broader, something like a sugar cane, while nocardia is much more thinner, like a string, like a vermicelli. So that is the difference between nocardia and fungus in a KOH. So that is one thing you need to understand, that you can have these kind of things in both these organisms. Culture is important, especially we propose that fusarium keratitis and aspergillus keratitis have to be treated differently. And in our country, we need to be careful in two fronts. In our country, in the US, it's very easy to treat a corneal ulcer because 90% is caused by bacteria. So you will not be wrong if you are going to treat it with antibiotics. But in India, 50% is bacteria, 50% is fungus. But adding to the complexity is the north-south divide. In north, it is only aspergillus, and in south, it is mostly fusarium. And the treatment part for fusarial keratitis and aspergillus keratitis may be slightly different. So PCRs are recommended, not really required for each and every case, only if you don't have answers to your culture and smears. This AI part, which once again this paper was referred by Prashant in his talk, if established clinicians, established cornea people can only differentiate it 65% of the time by clinical samples. Because in textbooks you see very distinct features. This is bacterial, this is fungus. But in real life, patients don't present like that. And so it becomes very difficult, and unless you have ancillary support system like microbiology, you are not going to differentiate bacteria and fungi. And so there is a need for something better than that, better than the clinical part, and that is where AI comes into play. And we have now published that if you compare it with clinicians, and if you compare AI like mobile net and other convoluted neural networks, it is very clear that in the future, AI is going to take over this. Maybe it may be just adapted with your slit lamp. Maybe it will be adapted with a very simple instrument, so that it is not a complicated stuff we are talking about. Maybe it may be just with your mobile phone itself, which may give a differentiation of bacteria and fungi much more better than a clinician. So we finished the diagnosis. How about the management? The management, the treatment is medical and surgical. Medical, you can use the antifungal drops either topically, intrastromally, or orally. In topically, there are mainly natamycin, which was discovered in the 1960s, still remains as the drug of choice. Now, why does natamycin still remain potent? Because usually you hear that a drug which is discovered in 2005 works very well for 2 or 3 years and then develop resistance and goes away. But natamycin, only one important thing to understand is it is used only in the eye. It is not being used systemically. It cannot be formulated to be used systemically. So it's used only in the eye. And most importantly, it is not used in agriculture. We are talking always about antimicrobial resistance and other things. What the biggest culprit for development of antimicrobial resistance is its use in agriculture. So natamycin is still potent because it is being used only in the eye and not being used in the agriculture also. It's still, in the study which we did, we found out that natamycin was better than voriconazole, and especially so, the difference becomes much more stark between fusarium and aspergillus. Fusarium, there is no doubt that natamycin is a much, much better drug than amphotericin. Intrastromal, the dose of voriconazole is 50 microgram in 0.1 ml, and amphotericin also has been suggested, even though it's toxic. But randomized control trials have shown no added benefits of using adjuvant intrastromal antifungals, though it has been postulated that instead of intrastromal, if you use intracameral, amphotericin B has some benefits. How about oral antifungals? The indications are when the lesions cross the limbus, if there is scleritis, if there is endophthalmitis, then there has got some role for these drugs like ketoconazole, voriconazole, fluconazole. But these are toxic drugs, and the liver function tests have to be done and have to be monitored if you are going to use it for a long period of time. But for keratitis, there is no benefit in adding oral voriconazole to the topical antifungal agents for severe fungal keratitis. Dr. Namrata Sharma has popularized this concept of TST protocol, the topical systemic targeted therapy. The first line, there is no doubt, you start with topical natamycin 5%, and in case it doesn't respond, you add systemic therapy in severe ulcers, and in the third line of treatment, intrastromal and intracameral, and fourth line is TPK. But with all this, if the ulcers are not healing, always check for diabetes mellitus. The patient may be a 17-year-old patient. The patient may be an 18-year-old patient, but please do check for diabetes mellitus before you have to treat this patient. Establish whether there is any chronic dacryocystitis. Ask the patient to show you the medicine and ask them to tell in their own words on how they are using these medicines. I have seen patients using hometropin drops every hourly and natamycin for 2 times a day. Sometimes patients wouldn't have understood what we have told in our rush for seeing more patients. And the contamination of medications also is very, very important. The drug which we have given it to them, if they are not keeping it right, that may be contaminated by bacteria. And so instead of fungal ulcer, you will be converting it into a fungal plus bacterial ulcer. So this is very important. How about the surgical part? Cross-linking, therapeutic keratoplasty, and miscellaneous surgery. In cross-linking, if you just use Dresden protocol, there is no benefit. However, there seems to be some benefit in bacterial keratitis, but if you change the photosensitizer to rose Bengal instead of riboflavin, there seems to be some benefit, especially in fusarial keratitis. There's a distinct difference between fusarium and aspergillus with regard to rose Bengal assisted photodynamic therapy. How about therapeutic keratoplasty? Unfortunately, in our condition, in India, therapeutic keratoplasty is the single largest indication for keratoplasty, and it is not a great surgery. It's almost like an amputation surgery, but the indications are perforations, progressive non-healing ulcers, especially if they are non-healing, but if they are not progressive, I would still request you to consider continuing your topical therapy. Take the therapeutic keratoplasty as a last indicator. Also threatening to involve the limbus, definitely there is an indication. So the aim of therapeutic keratoplasty initially is not to provide vision. If the vision is coming, then it's fine, because I find especially the fellows, they want to do a round graft with beautiful sutures, but the main indication is to get rid of the infection. So even if you do a sort of an irregular graft, as long as you take the infective part away, then you should be happy this thing. So these are the surgical steps, a routine thing, but these can be the sequelae. Sometimes you start off with a pre-op here and you end up very well. This is very rare. Usually you can have a active fungal keratitis with increasing infection, go for a TPK. Earlier, initially it looks clear, but over a period of time, there may be a rejection and there may be an ultimate failure. Or worse, it can be a fungal keratitis for which we did a graft. After 30 days, the infection can recur in the graft. So there can be 3 sequelae with regard to therapeutic keratoplasty when you do for a fungal ulcers. So in conclusion, it is a big public health problem. There is an estimation that in India, around close to 9 to 10 lakh people get infective keratitis every year. 9 to 10 lakh, and out of that 50% fungus, and prognosis is definitely poorer than bacterial keratitis. The choices are limited, and there are need to explore different cross-linking strategies. I told you the rose Bengal works better, but then there are definitely some more time to go before we develop a good cross-linking strategies. But TPKs can be considered as a last resort, but it has a higher chance of reinfection. Thank you very much.
After the infectious pathologies of cornea, we now move on to the structural part, and we invite Dr. Rashmi Deshmukh to please talk about the management algorithm for ectatic corneal disorders.
Good morning. I'll be talking to you all about ectatic corneal disorders and how to manage them. So initially, we'll just look at what is corneal ectasia and keratoconus. So in corneal ectatic disorders, essentially there is corneal thinning, and which causes visual impairment because of the corneal shape distortion, because it's no more able to hold its own shape. So it can be diagnosed with the help of corneal topography scans, where you'll see keratometric steepening, inferior irregular steepening in the keratometry maps, anterior and posterior elevation, which is usually coincident with the thinnest point on the cornea. Sorry, yeah. And usually keratoconus and adult corneal ectatic disorders are monitored for progression. If on the comparative scans over 3 to 6 months, the corneal topography does not change much, then it is called as a stable disease. But if you see that there is progressive steepening in the area of the cone, then it is known to be a progressive disease, and that itself requires a treatment for stabilization. Why? Because it is known to affect visual acuity. So sometimes the visual acuity itself can reduce over time because of a progressive disease, or a visual acuity can be maintained, but the quality of vision because of progression is going to reduce over time as well. So this is a broad overview of the management of keratoconus. Within 15 minutes, it is not possible to cover everything, so I'm going to give you a broad overview of things. When we are managing a corneal ectatic disease, we are mainly concerned of 2 things. One is we want to manage the progression itself. Second is we want to manage the vision of the patient. So for progression, we are going to look at collagen cross-linking. If the patient is not suitable for C3R, then usually we go ahead with a keratoplasty. And for vision, we start with spectacles or contact lenses. If it is mild to moderate, then usually you can perform procedures like PRK with C3R or ICRS combined with C3R, which can help in corneal regularization. And if it is more advanced, then stromal keratophakia has come about for corneal regularization, but I'm just going to touch upon it. So first, corneal collagen cross-linking. Before C3R started for keratoconus, it was only contact lenses and keratoplasty which was used. There was nothing in between. So if contact lenses are not giving good vision, we would directly do a corneal transplant. But it was known that the total collagen content of the cornea does not differ in keratoconus as compared to a normal cornea. It is only the corneal stiffness which is reduced by almost 70%. So that is how the concept of collagen cross-linking was developed. Normally also cross-linking is seen in a normal cornea with increasing age, with diabetes, which causes increased glycosylation, and with increased exposure to ultraviolet light. And what it essentially does is it increases the biomechanical stiffness of the corneal collagen. So it is making the cornea rigid so that it does not progress further. So what is the procedure itself is that the cornea is soaked with riboflavin and there is ultraviolet light exposure for at least 30 minutes at a dose of 3 milliwatts per centimeter square to achieve a total surface dose of 5.4 joules per centimeter square. This causes a biochemical reaction between the photosensitizer, which is the riboflavin, and the ultraviolet light. It can be an aerobic and an anaerobic reaction, which causes formation of covalent cross-links between the collagen molecules as well as within the collagen molecules itself, meaning between the fibrils. So the initial standard protocol which was described was the Dresden protocol, where like I just showed 3 milliwatt per centimeter square of ultraviolet light is given for 30 minutes after riboflavin soakage. But it was seen to be endothelial toxic, and it was told that it is safe only for corneal thickness up to 400 microns, which was the corneal stromal thickness for the safety of endothelium, which was prescribed. When one should cross-link is in a progressive cone. So if there is an increase of 0.5 diopters or more in 2 or more keratometry values in the steep meridian between two curvature maps that you are seeing in consecutive visits, but there is no corresponding area of flattening, that means the cone is progressing. And another criteria which is commonly followed is you look at the maximum keratometry value, and if it is increased by more than 0.5 diopters over 6 months, then you can go ahead for a cross-linking. But sometimes you might not want to wait for a comparative scan, and you might not want to wait to see progression. That is when a patient is presenting at a very young age, because they will be at a higher risk. You should also look at the grade of keratoconus, how advanced it is, and the corneal pachymetry, whether it is borderline, you might not want to wait ahead. Then certain risk factors like VKC or patients with developmental delay, you might want to cross-link in the first go. Again, depending on the other eye status as well, if the patient is one-eyed or if the other eye has had high drops, then you might want to cross-link in the first go. And if the patient is not available for follow-ups, is another time when you could consider cross-linking in the first visit itself without waiting for actual progression. Now, apart from Dresden protocol, there are accelerated protocols as well, which are based on Bunsen-Roscoe law. What is this law? Is that it's a photochemical reaction is directly proportional to the total energy dose, irrespective of the time for which the dose is delivered. So here the total surface dose that we want to achieve is 5.4. In Dresden protocol, we are giving 3 milliwatts per centimeter square for 30 minutes. In accelerated protocols, you are giving, the commonly followed one is the 9 milliwatts for 10 minutes or the 18 milliwatts for 5 minutes. And it still gives the same surface dose that can be achieved, but it saves some time. Now, there are different CXL machines which are available for collagen cross-linking, which can achieve certain doses. And your protocol might depend on the machine that you're using as well. What is expected post-op is the corneal stabilization, and at times corneal flattening is also seen over time. And on OCT, one can see a demarcation line like this, which is actually used as a surrogate marker for the depth of CXL effect, but it should not be taken as the actual depth at which collagen cross-linking has happened. It can only be used as a surrogate. So this was the basic about collagen cross-linking, which helps in stabilization of the disease. But for corneal regularization, it can be combined with either PRK with C3R or ICRS with C3R, which is intracorneal ring segments. So first, looking at intracorneal ring segments, they were FDA approved for the use of keratoconus in 2004. Before that, they were used only for mild myopia. So how do they work in ICRS, they are basically spacer elements which go between the collagen fibrils or the collagen lamellae, and they have an arc shortening effect like you're seeing in the picture above. And it is based on the Barreker thickness law, which says when you add material to the periphery of the cornea, or you remove an equal amount of material from central cornea, then you're going to have a flattening effect on the corneal curvature. So again, this is a figure to show how the ICRS reshapes the cornea. It creates an artificial limbus within the cornea. So, and there is a redistribution of the biomechanical stresses, which is more even after the ICRS, and it is expected to cause an improvement in corneal regularity and tomography. And the amount of flattening and regularization that you are going to get depends on the optical zone where you're placing it and the thickness of the ring. The shorter the optical zone or the smaller the optical zone, the more flattening you're going to get, and the thicker the ring, the more flattening you're going to get. Now, intracorneal ring segments are of three types. One is Kera rings, then you have Ferrara rings, and then you have intacs. For all practical purposes, we'll be talking about intacs henceforth. So in intacs, there are usually semicircular pieces of PMMA, which are around 150 degrees of arc length. And they are seen as you see in the image like that. You can either place a single ring or you can place a double ring based on the corneal topography. When you should use is that you should have a clear optical zone. There should not be any central scarring. It is usually good if the mean keratometry value is less than 58 diopters for regular rings. For 58 to 62 diopters, steep K rings are also available. It's not like you can't do it beyond 62 diopters, but the amount of flattening is going to reduce the steeper you go. The minimum pachymetry in the 6 mm zone should be at least 450 microns. This is because you want adequate depth for the intact channel to go in, and you should not have any perforation, so you should not go thinner than that. And it is usually used in patients who are contact lens intolerant. Which are the poor candidates for placing ICRS? When there's central corneal scarring, when the cases are still progressing, where you are still unsure about what the astigmatism and the axis is going to be. Pachymetry less than 450, like I just mentioned. And of course, we have to set realistic expectations with the vision, because this is just going to improve the visual quality and reduce the astigmatism, but this is not akin to a refractive surgery where the patient is going to get rid of the glasses. This is such that the cornea gets regularized because the patient is contact lens intolerant, so he can at least get some vision with glasses. So while planning, the ideal position of the incision is on the steepest corneal meridian, and it reduces corneal power of the steepest meridian to cause an increase in the flat keratometric reading. And the depth of insertion is usually 70 to 75% of the total corneal thickness at the incision site, which is at the 6 mm zone. It is usually recommended to stay at least 90 microns away from the endothelium to cause any damage. The channels can be created either mechanically or by femtosecond laser. And this is just a video to show how it is actually inserted. So here the femtosecond laser is creating the channel, and this is how the incision is made on the steep axis. Then once the incision is made, it is usually opened up using a Y spatula. So you open up the incision, and then this is so that you initiate the insertion of the intacs rings. Then you hold the ring perpendicular so that you go into the depth of the channel and you don't cause a false passage, and then you start pushing it into the channel. Once it is adequately inserted, then it goes in easily if you would just push it parallelly to the corneal surface. In the end, you can choose to suture the incision site, or you may leave it unsutured, but you should put a BCL then on top to prevent any migration of the intact rings. Here I've put a suture. Just an example of how a double ring would look, and in corneal topography. So the middle picture that you're seeing is the pre-op, and the first topography is the current picture. So you are going to see a corneal flattening and regularization within the area where the intact rings were placed. That is what is expected. When you combine it with C3R, the mean change in sphere expected is up to 5 diopters with a mean change in cylinder of up to 2.5 to 3 diopters. So this was the basic about ICRS. Now coming to PRK with C3R, again another thing which is combined with C3R for corneal regularization, which comes under the vision management category. So this is used again only for corneal regularization, not for not like a laser vision correction. You need to make sure that you have adequate corneal pachymetry, usually more than 450 microns, and you should have a residual stromal thickness of at least 350. We have to keep in mind that these are already weakened eyes, so we need not correct the entire corneal power refractive error and weaken the cornea further. Post-operative corneal thickness at least should be 400 microns, which would include the epithelial thickness as well. To see the target refraction, how you are going to plan the ablation, emetropia is never the goal, and that should be explained to the patient. And we have to keep in mind that cross-linking itself also causes some amount of flattening. So an undercorrection by at least 20% to 40%, depending on the protocol that you're using, is expected, because standard or resident protocol is going to cause a little more flattening than an accelerated protocol. And visual improvement is usually seen better with central cones as compared to eccentric cones. When is the collagen cross-linking done? In PRK with C3R, it is done immediately after PRK. In Intacs with C3R, it can be done at the same time, or it can be done sequentially. But in this case, you have to do it at the same time. You can use either accelerated or standard protocol. It can cause flattening of curvature post-op. And PRK should not be performed in an already cross-linked eye, because like I was mentioning, these are already weakened corneas. So you don't want to ablate a cornea which is already stiffened up. You don't want to remove any tissue further. So just to give an example again, the middle one is the pre-op photo, and the post-op picture is the first one, topography. And you see that in the area of cone, we are causing a flattening to eventually cause an improvement in the visual acuity. The cylinder is slightly reduced in this case. Then once collagen cross-linking and Intacs and PRK are ruled out, there would still be certain cases which are not okay for collagen cross-linking because of the advanced nature of the disease and the corneal thickness which is available, such as this case, where you can see that the corneal pachymetry is too low. Sometimes it can also happen that the corneas are too scarred, so even if you have a good thickness, you might want to go ahead for keratoplasty. So in keratoplasty, there is either an anterior lamellar keratoplasty, usually we go for a DALK procedure, or we can go for a penetrating keratoplasty procedure. This would be based on the level of scarring and the level of the disease that the patient has come with. If your scar is more anterior, like you have an apical scarring, then you might want to go for a DALK, because you will easily just remove the stroma and you can still have a clear cornea. But penetrating keratoplasty is usually considered if the patient has had eye drops before. There is one more lecture on lamellar corneal surgery, so this will be covered in detail hopefully in that. So overall, this would be the management of keratoconus algorithm. So it would depend on whether your cornea is progressive or non-progressive. If it is non-progressive, then you just need to manage the vision of the patient, which could be with spectacles or contact lenses. If the spectacles or contact lenses are not adequate, you could go for either keratoplasty or Intacs. If the vision is adequate, then you just keep monitoring the patient for progression. As long as the patient is stable, you just keep managing the same vision. But if the patient progresses, then you look at what the corneal thickness is. If the corneal thickness is adequate, you could go for C3R combined with any of the procedures like I described. If the progression has caused corneal thinning and you're not able to perform a C3R, then you might want to consider a keratoplasty. Thank you.
Thank you very much, Rasmi. Can we have the recorded talk of Dr. Rajesh Fogla?
We request the audiovisual team to please screen the recorded talk by Dr. Rajesh Fogla. He could not be here with us physically. His talk is on approach to pterygium.
I shall be talking about a common clinical condition, pterygium, and how you approach it in your clinical practice. I have no financial interest to disclose. Pterygium is a triangular wing-like growth consisting of conjunctiva and hypertrophic subconjunctival tissue. Commonly occurs in the palpebral fissure, mostly in the nasal quadrant. It may start initially as a pink aquila, and in advanced cases, it can encroach onto the cornea. Pterygium consists of a apical cap, head, and a large body. You can see a pigmented line in front of the apical cap. It is called the Stocker's line. You have the head, that's the encroachment onto the cornea, and what you see on the conjunctiva is the large body of the pterygium. The overlying conjunctiva may be normal, or it can show acanthotic, hyperkeratotic, or dysplastic changes, while the underlying stroma shows elastotic degeneration and the abnormal collagen fibers produced by the damaged fibroblasts. there is an increased prevalence around the geographic equatorial belt, possibly due to increased UV exposure, slight preponderance in males who work outdoors. It's more with increasing age, and it has been noted that colored skin has a 2.5 times risk of developing pterygium. Increased UV exposure is the most common reason. Reflection of light from the nasal bridge could be the reason why a nasal pterygium is seen more frequently. Further contribution occurs with the exposure to the sand and dust resulting in the microtrauma, the wind, and the desiccation of the interpalpebral area. There can be a hereditary or genetic predisposition. Immunohistochemistry analysis shows overexpression of p53 gene, suggesting role of dysplasia. Focal limbal stem cell deficiency may be associated with encroachment on the cornea, and there possibly is an additional role of human papillomavirus in the etiopathogenesis of pterygium. Clinical presentation can vary from the patient being asymptomatic or presence with irritation, foreign body sensation, dryness in the eye. A decreased vision can occur from induced astigmatism, or if there is encroachment of the visual axis with advanced cases of pterygium. Recurrent pterygium may also cause a double vision in different positions of gaze. Patients can also present for cosmetic regions when the pterygium gives a reddish, fleshy appearance. The grading of pterygium can be based on the extent of corneal involvement in terms of how many millimeters it encroaches onto the cornea, or it can be graded with the density of the pterygium, that is how well you can visualize the underlying structures. So in atrophic pterygium, you can see the underlying sclera, whereas in a very large fleshy pterygium, the structures may not be visible. You can also classify it as primary pterygium or a recurrent pterygium, or a classical pterygium and a pseudopterygium, which can occur following chemical injury or peripheral ulcerative keratitis, when it can be at any location, not necessarily in the interpalpebral area. And usually they are non-progressive, and in some cases you can pass a probe underlying the pseudopterygium. You can have a single-headed pterygium or a double-headed pterygium. Differential diagnosis includes pseudopterygium, as we just described, limbal dermoid, flick-tendular conjunctivitis with the hypertrophic conjunctiva, ocular surface neoplasia, conjunctival lymphoma, or sometimes with nodular scleritis or sclerokeratitis. All these, when they occur in the typical nasal or temporal location, it can be misdiagnosed as a pterygium. This flowchart gives an overview of the management plan of dealing with pterygium. Various techniques of surgical excision have been described, including the bare sclera technique, excision with primary closure, use of antimitotic adjunctive therapies, excision with ocular surface reconstruction using conjunctival or conjunctival limbal autografts with or without amniotic membranes. Bare sclera excision technique was described in 1948 by O'Brien. A simple excision of the head and the body of pterygium is performed without any closure. This technique has a very high recurrence rate ranging from 24 to 89%. And because you leave the sclera bare, there's increased chances of complications, scleral necrosis, scleral infection, and sometimes often leading to symblepharon formation and diplopia. Therapy using strontium 90 were attempted, which did reduce the recurrence rates down to almost 10%, but were often associated with complications like scleral melts, infections, cataract, dry eye, ocular surface disease due to limbal stem cell dysfunction. Use of mitomycin C, an alkylating agent, is commonly used in glaucoma surgery. It has also been described in the management of pterygium and has been applied preoperatively by injecting mitomycin C 1 month prior to the excision, especially for fleshy pterygium. The recurrence rate reported has been about 6%. Intraoperative application of mitomycin C 0.02% for 30 seconds to 5 minutes have been described, and recurrence rate vary from 3% to 43%. It can often lead to delayed conjunctival healing, corneal endothelial cell loss, and scleral or corneal melting. Post-operative use of mitomycin C in the form of drops, like BD or QID for 1 to 2 weeks, in an attempt to reduce the recurrence rate, has been tried. Again, the recurrence rate varies from 0 to 38%, but again, the complications of scleral melting, scleral or corneal perforation, secondary glaucoma, cataract, all have been described. Mitomycin C, the alkylating agent that inhibits cellular division by inhibiting cellular DNA and RNA, sometimes has a long-lasting effect. And because of this delayed healing, it can result in scleral melts, associated perforation, and at times it can also lead to infectious scleritis as well. Pterygium excision combined with ocular surface reconstruction using conjunctival or conjunctival limbal autografts is currently the procedure of choice worldwide. It's associated with the lowest risk of recurrence, minimal risk of complications, and excellent cosmetic outcomes. It can also be combined with amniotic membrane transplantation when dealing with recurrent pterygiums. Randomized clinical trials comparing conjunctival limbal autografts to mitomycin application or amniotic membrane transplantation alone have shown better clinical results with the use of conjunctival limbal autografts. This clinical photograph shows the outcome of a conjunctival autograph following excision of a pterygium, and the autograph was secured using 10 or nylon sutures. Fibrin adhesives are biological and biodegradable, consisting of two components, fibrinogen and thrombin, which on combination form an adhesive fibrin. Advantages include shorter surgical time, greater patient comfort, and reduced recurrence rates. However, it's expensive and also has the risk of getting contaminated. Autologous blood has also been used successfully for the same purpose, and it may be a reasonable alternate. And the cornea looks very clear. On topography, you can see that the pterygium was inducing almost 11 diopters of astigmatism. So it's usually like a with the rule astigmatism because there is horizontal flattening. And after excision of pterygium, that astigmatism has dropped to about 0.7 diopters. The perfect technique, which stands for pterygium extended removal followed by extended conjunctival transplantation was described by Laurie Hurst from Australia. Has 0% recurrence rate for primary pterygium and 1% for recurrent pterygium. Now in this surgical technique, a large area of conjunctiva is also excised along with the pterygium, extending all the way to the caruncle. And then you prepare a conjunctival graft and cover the entire bed. This also gives very excellent cosmetic outcome, and the recurrence rate in a large series of 250 eyes with a follow-up of 1 year was noted to be 0%. In the post-operative management, we use topical antibiotics at least for a week or two till there is complete both corneal and conjunctival epithelial healing. And topical steroids can be used for 2 to 3 months in tapering dosage to control the surface inflammation, but watch out for steroid responders, so monitor the intraocular pressure. Topical lubricant eye drops can be used for an extended period of time for 3 to 6 months, and we advise the patient to use UV protection sunglasses while they are outdoors. The follow-up typical schedule is on day 1, day 5, to day 14, 1 and 3 months. What are the complications? You can have the graft edema, hemorrhage under the graft, the Dellen formation. If the graft is swollen, then the adjacent cornea can become dry. You can have displacement of the graft or retraction. That's why I like to put stay sutures at the limbus. You can have loss of the graft. Donor side, you can have sometimes formation of Tenon's granuloma. Sometimes it can also occur at the edges in the site of excision. And obviously, you have the recurrence of pterygium. This nice paper from Harminder Dua, they looked at the healing of the conjunctival grafts, and they found that yes, you do get retraction at the edges. You can get that serous fluid under the graft. This, if it occurs, you can just puncture the conjunctival graft using a needle to release the fluid. You can have hemorrhage, and sometimes you can have the formation of granuloma. How do you manage recurrence? By doing a meticulous primary surgery so that there is no recurrence. In the early stage of recurrence, you can try increasing the frequency of topical steroids or giving sometimes subconjunctival 5-fluorouracil or anti-VEGF injections. And if none of these work, then you have to do a repeat surgery, and at that time you can use a topical mitomycin C application, or if you are short of conjunctiva, you can also combine it with amniotic membrane transplant. So basically, in conclusion, pterygium is a common disease in the tropical belt, and in advanced cases often requires surgical excision. Conjunctival autografting is currently the gold standard for surgical treatment. Meticulous surgery and the use of fibrin glue can reduce recurrence rates and give excellent cosmetic outcomes. Intraoperative mitomycin C application has a role in recurrent pterygium surgery. Amniotic membrane transplantation has an additional role in surface reconstruction, especially in recurrent cases where it requires extensive removal of the pterygium and you have a large stromal bed that you need to cover, and requires longer time for resurfacing with conjunctival epithelium. Thank you. Thank you for a patient hearing.
With this, we come to an end of the session 1 for Eyeshala. Unfortunately, Dr. Namrata Sharma could not join us in this session. Please come back for session 2 of Eyeshala, which shall begin at 11 a.m. Thank you, all the speakers, for your great insights on the very important topic of corneal pathologies.